And with that, I would like to welcome our first guest to the stage for our opening session. We're going to get to hear from Dr. Lee Cohen about a new film that he's produced. We also, as folks know who've joined us before, always like to start with a story. And instead of hearing one person's story this morning, we are going to hear several stories through a short film that Dr. Cohen has produced called More Than Blue. Before we show that film, we're going to just talk for a moment. And then also Dr. Diana Clarke is going to be joining us after we screen the short film. So welcome, everyone. We're so excited to get started. So Dr. Cohen, welcome.
Thanks so much.
Before we get started, I want to hear a little bit about your work at Mass General Hospital and leading the Women's Mental Health Center. Tell us about your work. You are an icon in this space, I think it's safe to say. Tell us what you do at the center.
So first of all, thanks for inviting me. It's such a pleasure to be here. And I got interested in maternal mental health more years ago than I frankly would like to admit. But I was a resident in psychiatry, and it was such an interesting time in psychiatry. We were learning so much more about mood and anxiety disorders, both in men and women. But what was clear is that there was a lack of focus on how to help patients and the clinicians taking care of them navigate mood and anxiety disorders during pregnancy and the postpartum period. And we started a small consultation service which grew. And the goal of my work and the work of my colleagues at the Center for Women's Mental Health, where I'm the director, has really been to mitigate suffering, to provide the best information to patients who were making such critical decisions about what they were going to do across pregnancy and then into the postpartum period. As a developed country, we have, even on the other side of screening for postnatal depression, we still have inadequate and incomplete care, where the majority of patients who suffer from postpartum depression do not get adequate treatment, and we're not getting moms well across America. So about 5 years ago, I got asked at a meeting, after doing this work for 35 years, sort of what was left, what did I want to do? And I said, after that recent study that got published that showed that for women who presented after they screened positive for postpartum depression, that looking down the road, we were in single digits a year out as to the number of those patients who were well. I said we needed to do more. And so I didn't think we needed a new clinical trial, even though I'm a clinical trialist, and I'm so interested in studying both older and newer interventions for postpartum depression. As an example, I said I think we need to do more and hear the stories of patients across America who were suffering with postpartum depression, about their journey, where they were, and also how they got well. And we got philanthropic funding to produce More Than Blue. And I get asked, what did I learn as we were producing and making this film? I really learned about the isolation of patients who are suffering from postpartum depression during one of the most precious times in their lives. And so fast forward, More Than Blue is complete. You're going to see just a few select scenes that we pulled together regarding, from the film. But I'm so pleased that we're in the middle of an impact campaign across the country. We've done about 60 or 70 screenings of More Than Blue, and on April 15th, it'll be on the streamers on demand. It'll be on Prime Video. It'll be on Apple TV, YouTube Video, and Google Play. And so we're so excited that the message of More Than Blue, which is that postpartum depression is an exquisitely treatable illness and that moms don't have to suffer, that will hopefully be out there in, frankly, a global way.
That's an incredible introduction. So 1 in 5 women will suffer from a maternal mental health disorder, and very few will receive adequate treatment. We actually have updated treatment data on a panel tomorrow, which I think you'll be pleased to hear about. But without further ado, Let's listen to More Than Blue.
Being a mom was always part of my plan.
Seemed like the thing that everybody does.
I would have 3 kids exactly how I grew up, a house with a backyard and a dog, like the stereotypical family.
It's supposed to be this blissful time, the happiest, most magical time of your life.
No negative feelings, just love, just happiness.
We only see this one idealized, perfect sunlight streaming in the window on you cradling your newborn, and, everything is just perfect, and that is just not the reality.
I didn't know. Is this the baby blues? It was just pure, grit and terror getting through every single day. Okay, I guess this is motherhood.
I had expected things to go a certain way, but what I was experiencing was so far out of my expectations. And that gap between expectations and reality that's my depression. That's where it lives.
Postpartum depression is not something that was ever brought up in my household, so I didn't really recognize it. I didn't think it was something silent.
I wouldn't say that I was especially concerned about it happening to me, but I knew, I knew what the numbers were, so I knew it was possible.
I was like, I'm starting to feel kind of sad. I'm starting to feel a little anxious. Is this normal? Maybe I'm not a good mom, or maybe I need to do more. They don't really tell you at the level of when you should call for help.
The sadness started as soon as I gave birth and got deeper and heavier every single day.
My mother's generation, they didn't talk about it at all. I'm sure my mother had postpartum depression, but we didn't have a name for it then. There was this image of motherhood, and it was perfect and wonderful, and women were smiling, and the men went off to work, and the women stayed at home, and they had dinner on the table every night. They loved every minute of being a mother. There was no sadness. Maybe they mentioned the baby blues, but women were just told,
"Don't worry about these blues. It's a normal reaction to having a baby and the changes that take place then. Get out to a beauty parlor, dinner with your husband, or have a good friend in for a visit.
And you'll be just fine."
When you go out,
You couldn't say you didn't love it, because you were supposed to love it.
If a mom came into the office with postpartum depression, there was a sense that she'd get on the other side of it quickly. There wasn't a sense that women experiencing those symptoms had a bona fide disorder.
We do know that 1 out of 5 women experiences postpartum depression, but the public narrative around it had been very narrow.
I stopped feeling like a good mom. And I started to really just spiral again. There was a period of time where, for 5 days, I don't think I showered, and I didn't sleep well. It was really hard for me, even to get dressed, to make myself food. I was just so overwhelmed by everything, and my world got so much smaller.
My perception of postpartum depression was women who couldn't get out of bed to take care of their children, constantly crying, didn't want to do the things that they do every day, bring them joy. And I didn't feel that way. I could muster getting out of bed, taking a shower, taking care of myself. I cared about my appearance. I wasn't living in 7-day-old pajamas. Like, I could go out and about with my son. So I never had a perception of, oh, I have postpartum depression. But my lack of knowledge of other postpartum mood disorders gave me a false sense of, oh, I guess this is just really hard.
This group is definitely a support group. I'm not being their therapist, I'm not doing therapy. I'm sort of working to facilitate them in supporting each other. There is something that's amazing about sitting in a room of people who are all going through the same thing. When somebody's sharing and I look around and I see other people nodding, like just so nodding so hard, and you're like, oh, okay, they feel not so alone in this moment. That's pretty amazing to be part of that and to know that I created that space, but also the other women in the room created that space.
There's all of these ways where mothers own all of the blame and all of the shame and guilt for creating symptoms and not overcoming them when they should. And I think that the shame can be such a filter through which they perceive themselves.
Thankfully, we have so much evidence to really prove that, something actually is happening and it's biologically based.
Our brain sits in a giant sort of neurotransmitter soup that's impacted by our hormonal changes during pregnancy. You have rising hormones and you have rapid fall-off of those hormones at the time of childbirth, and that's normal physiology. And the profound changes in all ways, from the biologic, the hormonal, the psychological, all of it is interconnected in ways that's going to influence who's at risk.
We know that half of women with postpartum depression go undiagnosed, and among the ones that are diagnosed, fewer than 20% actually get treated.
I do have a therapist that specializes in postpartum, and he has just been such a light. I've been seeing him for about a month and a half, and he just makes me feel like this isn't a permanent condition. This isn't something I'm stuck with for the rest of my life. And I'm really able to talk about my childhood and the trauma that I went through so that I can be a better mother.
Psychotherapy is extremely helpful for women to understand the mental illness, their experience with it, observing their own symptoms, so that they can go to a place of acceptance of what's going on with them.
Antidepressants, SSRIs, have been in the field, some of them, for over 40 years. So we have research for over 40 years.
And what we understand about the efficacy and safety of antidepressants is that majority of them are low risk.
It had taken so much for me to come to terms with, I need to breastfeed and take medication. But the longer I stayed on a medication regimen, it was like, okay, I feel a little lighter. And then I would start to notice I can do more, like I made breakfast and dinner today. And maybe we got fast food for lunch, and that's okay, but you just start to notice these little things. Oh, they spilled milk? I can clean that up right now, and not just, oh, they spilled milk. It's just gonna stay there. I can't clean that up. When you're depressed, you're just a shell, and you're seeing everything happen, but you're not really there, you're not really engaging in it. And I remember kind of coming out of that and feeling like a person again. And that's kind of when motherhood did become really joyful again.
I think a very clear message that we try to convey to the mothers that see us is that perinatal mood and anxiety conditions are common, nameable, and treatable. And treatment can include medication, talk therapy, family involvement, and also many other things that we know from research and from our own experience can be hugely life-saving.
Over the years, I've worked through a lot of what happened to me. I love our son. He's perfect. He's amazing. But when a lot of our friends started having kids, and I would see how joyful they were and happy, there were so many times where I would look at this like newborn baby or a month-old baby and be like, I didn't enjoy it. I didn't hold him enough. I didn't just unabashedly enjoy every little thing he did because I was so terrified the whole time. And looking back, I have a lot of guilt about that. Ready? But I think my experience has also made me more vulnerable and open. I've become more patient. All my priorities are shifted. I look at the world differently. I just feel like a different person completely.
This experience has changed my life in such surprising ways.
My path to recovery has been a really long journey.
Motherhood is the most transformative thing that will happen in someone's life. And we are not doing a good job helping people be prepared. But if we approached every single mother, and if every single healthcare professional having contact with that mother would say, we know one of the most likely complications of this pregnancy will be a mental health concern. Let's talk about that honestly, and let's ensure you're going to get the support and or treatment if needed. That would be just a game changer.
My vision is that in a country like ours, women will have access to care, whether we're talking about medication, antidepressants, whether we're talking about non-pharmacologic treatments such as certain psychotherapies, and that the clinicians taking care of them, regardless of their specialty, will have the tools and the knowledge about how to use them to get those patients well.
We have to give hope. I just said to a woman yesterday, she asked me as she was being admitted into a hospital, will you promise me that I'm going to be myself again? And I said back to her, I promise you that you will be yourself again. You're not alone, you're not to blame, and with the proper treatment, you will be well.
Thank you, Dr. Cohen.
Thank you.
This session is titled Faces and Voices of Maternal Mental Health Disorders and the latest research on barriers to care. So we're going to pivot to the latest research on barriers to care. And I'm so thrilled to welcome to the stage Dr. Diana Clarke. She is the research director at the American Psychiatric Association and has been able to do some incredible research that we were so thrilled to partner with on, funded by the CDC Foundation and others, to really bring to life what are the remaining barriers to maternal mental health care in America for both patients and providers. And with that, I am thrilled to turn it over to you, Dr. Clarke.
Okay, thank you. I'm so excited to be here, and sorry I was tad late. Thank you guys, and formerly 2020 Mom, Policy Center for Maternal Mental Health, for partnering with us and supporting some of our funding the part of the project. Next slide, please. So I have no financial conflicts to disclose. Next slide. And of course, these are my thoughts and my co-authors, and not that of the CDC or CDC Foundation or the APA and its board of trustees or members. Next slide, please. So this project came about because the CDC was actually hearing this anecdotal report that individuals with mental health conditions, when they became pregnant, they were being dropped by their mental health providers. And I remember when they first reached out to me to talk to me about this, I thought, well, maybe not all mental health providers, and maybe there's just maybe depending on their training. So that was my thought. And so we started off this research project. Next slide, please. And so what we did was we decided to bring together, because that idea was in my head, not all providers. And so I decided, well, what would be really good was for us to not only hear what the pregnant and postpartum individuals had to say, but to also hear what the behavioral health providers had to say, whether different levels of training, and then also what the non-behavioral health providers who are actually seeing these patients first, what do they have to say? And so I'll talk a little bit first about the pregnant and postpartum survey. We did some first surveys as well as focus groups. And the age range of individuals who participated in the pregnant and postpartum surveys and focus group ranged from 18 to 45. And so you can actually see the distribution of their state of pregnancy. So some were currently pregnant. We had a few people, most of them were, in their first year postpartum, less than, and then 1 to 2 years postpartum, and that other are people who might have lost their pregnancy, etc. So that's what that other category represents. Next slide, please. So the focus group was so informative because what we heard from pregnant and postpartum persons were they identified their symptoms as we saw in the video. They're experiencing these things, and it took a lot for them to overcome that initial barrier. Oh, why am I not excited about this pregnancy? Or why am I not happy to have this baby? I'm supposed to be full of joy. They overcome that barrier sometimes and try to seek help, and they're reporting those symptoms. But the symptoms were not being validated. So the clinician might ignore the symptoms, tell them it will go away, it's normal. Or they felt like some people felt like they were being deserted, right? They were completely deserted by their providers. And others felt, well, I felt like when I started talking about it, I felt like the provider wasn't listening to me. I feel like I wasn't there, and so I feel like I was being discriminated against. So that was really a difficult thing to hear, right? So next slide, please. So we actually figured, okay, so we're hearing this from just a small group of individuals in the focus group, so let's see what we will hear when we do a broader survey. And so what we're finding in the survey is that individuals do talk about some of the barriers that they experience. And some of those are, some people experience no barriers, and those are the happy, lucky individuals, but others experience structural barriers. And when I'm talking about structural barriers, I'm talking about some of them have no internet connection, right? I remember even for the focus group, people actually went in their cars or outside to participate because it was virtual focus group. Not having transportation, not even having the insurance to cover things, and then not having funds to cover childcare so that they can go for help. Time barriers, not having the time to go, they have competing priorities, and then the time that they have to wait to get that appointment. So that was actually really a challenge as well. And as I said, then the systemic barrier was primarily around trying to reach out for help, getting referred, and that not getting an appointment. And I'll show you some of the information from the non-behavioral health providers as well as the behavioral health providers. And that piece about unable to get an appointment resonated across all groups. So we also decided to interview in focus group format the behavioral health providers and do surveys of them as well. So next slide, please. And so we had in our behavioral health provider group, we had psychologists, social workers, psychiatrists. I'm at the American Psychiatric Association, so psychiatrists, of course. We had physician assistants, we had counselors, and we had advanced nurse practitioners. And so you can see the range of individuals who participated. So you do see that the majority of those who participated and completed their surveys were social workers. Next slide, please. So here's a snapshot first of what providers had to say. And this is behavioral health providers. They feel like only a handful of them, or behavioral health providers, are certified and have that specialized skill to provide the care. And even an individual who has actually gone out and ensured that they have the training. That's another thing that the behavioral health providers talk about, that to get that training, they have to find the time on their own. They don't get time off to do this, their own time and funds to pay for this, to get this specialized training, because it just doesn't exist in their program. And they just cannot find this expert for consultation. It's very difficult. And I know the PSI program has kind of helped, but they still find some challenge with that. Next slide, please. And in particular, here's the one that was really, really challenging, especially a behavioral health provider who specializes in perinatal mental health and specifically substance use. And already these women or these pregnant persons who have substance use disorder or substance use issues are even further stigmatized. Even when I was doing the focus group, my pregnant individuals who had substance use issue actually asked me if they could stay off camera. So that stigma was right there. So I could meet with them initially, but in the full focus group, they stayed off camera. So you see that that stigma carried forward. So when we ask about what are some of the perceived barriers, and I'm so sorry that the fonts are so small, but some of it is lack of available expert consultation, which I talked about before. So you see that that's a huge barrier. Some clinicians thought there were no barrier. They had the skill set. They are able to do it on their own. And that is just amazing. But we just have a few of those individuals who have that reproductive kind of psychiatry or mental health training. Some people have lack of time to address the complex nature of the problem that's being presented by the pregnant or postpartum person. And the lack of time wanting to get that specialized training, but just not having the time to do it. And people just don't feel prepared to do it. They don't feel well prepared, and so I can't treat them, so I'm going to have to refer them out, even though I'm a behavioral health provider. So I need to refer them out, and then the time to get that the person to get that appointment. Next slide, please. Here's something that I thought was kind of interesting, and you know, a lot of times we'll talk about that a lot of mental health providers don't necessarily take insurance, but what we find is that majority of the providers who participated in the survey did take insurance, right? But of those, only 37% accepted Medicaid and Medicare. So you see that the disadvantaged group is even further disadvantaged. And then among the 25.1% that actually did take insurance, the reason for not accepting insurance was the low payment or reimbursement, and then administrative challenges. So they talk a lot about the process they have to go through, the denial of claims, and then after it's been denied, and then resubmitting and all that stuff. And so that's part of the reason why they don't accept insurance. Next slide, please. But the good news is that most of them do say that they do that super bill, where they give the individual the form and then let them submit it to their insurance to get reimbursement. But think about it. Here's a person who is very depressed, postpartum depression, postpartum psychosis. They go in for care, and they're being given, they're having difficulty even getting out of bed, as we see in the videos for some people, and yet they're being given an insurance form to get then to submit to their insurers to get reimbursement. It's not going to happen. So then it's creating financial barriers for these individuals as well. So here's a snapshot from our non-behavioral health providers. So they talk a lot. So the non-behavioral health providers, we had, I'll talk the slides are a little bit out of order, but you'll see the makeup of those. So we had gynecologists, OBGYN, we had family medicine, we had a few people who are emergency physicians, and then we also had midwives or doulas who participated. So they also talk about how it would be helpful for there to be training on how to manage, treat, or counsel individuals, especially those with substance use disorder. So substance use disorder and psychosis were the two most challenging, which makes sense. And so they hope that they wish that they were training and they could get CMEs for these type things. And they also talk about the only way to get a patient a psychiatry appointment is in a reasonable amount of time is if they're actively suicidal. right? And we hear pregnant postpartum person talk about that even during the assessment, that even using that term suicidal sometimes don't even get them the care that they need. But it's only when the patient is suicidal, and even then it involves the ED, which doesn't have that continuity of care. And they have to wait between 6, 8, and 12 months for that person to get that appointment. Just imagine someone in their pregnancy and this is what they're experiencing, and then just trouble finding practitioners. So next slide, please. So this is just the distribution of the providers who participated. So you see that there was mostly OBGYNs and some family medicine individuals. Next slide. So what are the barriers? So here you're seeing that it's similar, right? So the barriers that they're reporting are the lack of comfort with prescribing medications, their concerns about liability, what's going to happen to the fetus, the available, so here's where, so the most important, the one that's most frequently endorsed, the lack of available expert consultation. So that's the same thing the behavioral health providers talked about. Lack of time to obtain the specialized training, lack of time to address the complex problem, and lack of training or expertise in reproductive mental health. So you see, whether you're a behavioral health provider or a non-behavioral health provider, you're seeing some similar issues that they're barriers that they're facing, and then on top of that, the concerns about the liability and lack of comfort with prescribing. Next slide, please. And so we actually specifically ask about billing for Medicare, Medicaid, for maternal mental health. And so you see that a significant portion of the people billed for Medicare, Medicaid, 37%, but majority of providers didn't. And they did not bill because they did not know if they could bill outside of the global capitation rate. And then some did not bill because they did not know the codes. So that was so making those codes accessible to individuals would be useful, and providing information so they know that they can bill outside for the global capitation rate is important. Next slide, please. So in summary, perinatal mental health care is important for the health of the parent and the offspring, and we know we have barriers such as fear of discrimination, stigma, lack of access to care, and for the practitioner we see the discomfort, the lack of training, and the lack of time to obtain the resources they need and the necessary training. So we know the barriers to perinatal mental health care are real, but we know that they're solvable if the patient, providers, and systems can work together. Thank you so much. And can you go to the next slide? Only because I do want to acknowledge that I didn't do this work alone, and I always want to make sure and that I had a huge panel of expert advisors, perinatal psychiatry. We have individuals from psychology, counseling, nursing, social work, and some of the members from CDC. So we bring all these people together to help us plan this project and to work through some of the kinks. Thank you so much.
Thank you, Dr. Clarke. Why don't you join us over here for just a few minutes of conversation? I'd like to ask each of you to reflect on, what are one or two things that really stood out to you from that presentation? And I think I'll start just by naming the obstetric provider barriers around can I bill, can I not bill, and the mental health provider barriers around equitable payment and the paperwork, right? The paperwork that comes with contracting with health plans, fighting for reimbursement and payment seems very substantive. And we'll be talking about some of those things on our panels throughout the next couple of days. Diana, do you want to share next with what surprised you out of these results?
Okay, so I think, and I think I kind of stressed it when I saw it, that the barriers were the same, even for the people who we expected to have the training, the behavioral health providers, the psychiatrists. And they're sitting in the room saying, we don't have that training, we don't have that specialized training, and it's important for us to have that training. So some of the work that we've been doing since we did the study is that we've gone to ADPERT, so that's the American Association for Training Directors for Psychiatry program, and we've presented this result and stressing the importance of having a reproductive psychiatry component and training built into psychiatric training. But we also need that in, because among the psychologists who participate, they talk a lot about getting the training and taking the courses to have the training. But at the same time, they need that collaboration with the prescriber so that not only can they support the individual, but to support them in terms of the signs and symptoms that they're experiencing and talk them through counseling, but support them in sticking with their medication. Because if you understand it and you're in collaboration with the prescriber, then you're able to ensure that the patient gets a well-rounded care.
Care teams in our next panel actually talk a little bit about that too. Any reflections from you, Dr. Cohen?
Thank you for what is just such a terrific talk, such critical work. And I was thinking as I was listening to your comments, if I could wave a magic wand and shift one thing, it would be to sort of raise the level of knowledge of colleagues, but not just my colleagues in reproductive psychiatry, nurse practitioners, PAs, nurse midwives with specialty training in reproductive psychiatry across the country, and almost so that we sort of raise that level of knowledge, which is doable. Yes. And, you know, I think that we're seeing it with my colleague Jennifer Payne is here. She'll be speaking later with all sorts of curriculums, the work that we're doing with virtual rounds at the Center for Women's Mental Health, using webinar format for free across the globe. I think we can increase that knowledge base. But I also think it's critical that as our colleagues get up to speed, because in one of your slides it says, even with a couple of years of training, I'm still a little shaky. I think there has to be a way of getting back to the mothership with sort of consultation to providers who are getting up to speed. Yes. But what I was actually inspired, I mean, you talk about systemic barriers, but I was inspired by your talk because I think this is a fixable problem.
I think it's fixable as well. I agree with you, right? And I also think one of the things that I think we also need to do, as we're educating the providers, I think it's so important for us to also educate family members and friends, because so many people have these, and partners, so many people have these signs and symptoms, and it's the people around them that notices it first some of the times, and they're not sure what they're seeing. So they're saying, oh, get over it, snap out of it, right? But if they understand it more, then they can probably help to support them and get them to care even faster as well. So.
And in the most emergent situations, for example, with postpartum psychosis, have those family members bring those patients to the emergency department so that they get evaluated.
Yes, absolutely.
This is such a fun conversation. And I think at lunch, we can continue to have this conversation. I know I want to talk more with both of you as well. Dr. Clarke, thank you for your research. We really needed a refresh, and thank you to the funders, CDC and others, for knowing that this was necessary. And Dr. Cohen, we all can't wait to screen. I want to watch the full film. I haven't done it yet. And then perhaps one of your takeaways will be to show this film to friends and family. So thank you both for this opening session. We so appreciate you.
Okay, thank you. Oh, and by the way, these papers have been submitted. So we have 5 papers that came out of this project, and so they're submitted for publication. And I'll let you know. I'll let Joy know, and so she can share it so that people know when they're available. And I'm doing it in an open access journal, so people can get access.
Yeah. Thank you.